go there, we more and more see very poor and bone-challenged people. And the question here is cement or no cement, and industry has brought us more and more complex screws and perforations and cement patterns, and there's a certain risk. I'm certainly one who can talk about that for days. So give us your viewpoint, David. Should we use cement or not?
Okay, so I think cement has its place, but I also think it's overused. And I think that there are other alternatives through which you could lower the amount of cement that you use. So in this talk, I'll talk a little bit about why not cement, but really, just did it again. I'll talk more about alternatives to cement augmentation. So this is kind of an outline of my talk. I'm gonna talk a little, I'll give a nice introduction, talk about the challenges of osteoporotic spine fixation, talk about intraoperative technique, and also care for the patient does not end in the operating room. It's also what you do after the surgery that matters, and then I'll just give some concluding remarks. And so we all know that the population of the US is aging. We also know that osteoporosis is the most prevalent bone disease in the world. And with our aging population and kind of modern medicine, the old are not slowing down. 80 is the new 60, and so on. And so that leads to an increased incidence of osteoporosis in trauma. And so it poses a unique challenge, and this is due to the reduced bone mineral density, which compromises the fixation strength of the screw. This increases the risk of complications such as screw loosening, pullout, implant failure, adjacent level fractures. These patients are often medically frail as well, and kind of as part of the AO mission, we want patients getting up and moving. We don't want them to be bedbound. So there's also the need for early mobilization. So when looking at the surgical options, we have multiple options available to us. Dr. Abdul-Jabbar will talk about cement augmentation, but really this talk will focus more about screw modifications, alternative anchors, and construct strategies. But I need to talk about a little bit why not cement. So while it's a popular technique, you risk leakage into the canal that could cause cord compression. I've seen some horrific CTs of an encased cord with cement. You could have cement embolisms. I don't know if you've ever seen the contrast studies, but after you cement and you look kind of like at the perfusion images of the lungs, it's pretty amazing. And as I mentioned before, a lot of these patients are they're medically frail, and so that's just playing with fire. Sometimes you solve one problem, but you just transfer it to the other level. So it's not uncommon for us to see osteoporotic fractures above the level of cement. In addition to whoever here has done joint replacements, especially the knee replacements, that cement gets to be pretty hot, and that could cause bone necrosis and could potentially even be a non-union generator and cause healing issues down the line. And then when you need to go and revise a construct with cement, it's just a nightmare. And so I like to avoid it when I can. And so I'm going to kind of go over some tips and tricks of what you could do to address osteoporotic bone in trauma that does not involve cement. So first thing is screw modifications. Overall, it's quite simple. We want as much of the screw to engage the bone to improve fixation. Very simple. Decrease pull-out strength, it goes better. And so kind of the basics, you could increase the length and diameter of the screw. That increases the contact with the bone. the larger the ratio of the outer diameter with the inner core diameter, the more the threads manage to engage with the bone. In addition, a lot of recent technology has kind of made a chevron shaped threads to help prevent pullout as well. Another option is using conical screws. As you can see in the screws in this image, the screw on the left is purely cylindrical threading with a cylindrical core, while the one on the right has a conical core, and this increases the ratio between the threads and the actual core, resulting in more engagement of the threads with the bone, increasing pull-out strength, as this study over here confirmed as well. I'll be honest, I have not used the expanding screws. However, it is both interesting, but I also have my concerns about it. So the thought behind it is you put in the screws, and then you expand the distal aspect in the vertebral body, and that increases the contact area. So first of all, one of my concerns with it is if you then need to revise it, or if you have pullout, it could be catastrophic. You can't just helicopter out the screw. But also another thing that people don't really talk about is when you expand that area, you actually shorten the contact area a little bit, and so you lose a bit of your functional length with the bone, which I think the argument is you make up with it with the increased diameter of the screw, but that's still some fixation that is lost. And then another option, which isn't available at all places, but is also interesting, is your coated screws, which help fuse to the bone. But again, if the patient has bad bone, even if it fuses to the bone around it, it may just break through it. So now I'll proceed and talk about some of the techniques that are out there. And so we all know bicortical fixation in a bone is strong. And so that holds for the vertebral body. The cortical bone is stronger than the cancellous portion of the body. And so if you put a screw with bicortical fixation, you're going to have better pull-out strength. Another thing is either no tapping or under tapping. Personally, unless the patient has super bone, I don't tap at all, especially with the screw technology that we have nowadays. When you tap, you just decrease the contact area between the threads and the bone, and I think it's been shown to weaken the pull-out strength. Another strategy is to use a screw with a cortical trajectory. As we know from from intertrochanteric femur fractures, you want to put the screw where the bone is. That's why in intertrochanteric femur fractures, you kind of aim the screw down to the inferior aspect of the neck where you have the good bone. Well, it turns out that along the pedicle and the lateral aspect of the vertebral body, that's where you have the better strength. In addition, under the end plate, you have better density of bone. And so if you look at the green screws in this diagram over here, those are cortical screws, and you're really guiding the screw along the trajectory of the denser bone to increase the pull-out strength. Another technique that could be done is you take a starting point that's a bit more lateral and a more medial, and to get triangulation of the screws, which also helps increase the pull-out strength. And then another technique involves just putting in 2 screws. The downside of this is you need to use screws of smaller diameter, and it can be kind of futzy, but some people do this, and it's been shown to be biomechanically stronger. Other considerations to take account. You could do a longer construct, that will increase the strength of the construct, but then you're also stressing the adjacent levels more. So I always go back and forth, and I think it ends up kind of finding a Goldilocks zone of increasing the length, but also knowing that you may be causing issues adjacent to that construct. In osteoporotic constructs, I actually tend to use a lesser rod. I use titanium. I will not use cobalt chrome because that causes a larger mismatch between the bone and the construct, and that will induce a higher level of screw pull-out. And then there are other options such as supplementing the construct with hooks and wires to get extra fixation. Here I have a nice little table summarizing a lot of the techniques and aspects that I discussed, as well as a few other ones. This is actually a pretty good paper. I forgot to. It's behind it. But there you have the summary table. And then this wouldn't be a good talk if I didn't mention bone health. At the end of the day, you can make the best construct in the world, but you're basically putting screws in balls of wood instead of a nice oak or pine. And so you want to try to make a better metabolic environment. And so when all is said and done, the patient still has osteoporosis. Even if they're not going to fracture that level again, they have many more vertebrae that they could fracture. And so I hook these patients up with a metabolic bone specialist, whether it be an endocrinologist, primary care, or whatnot. And also, I like to start them pretty quickly when able on anabolic bone-building drugs, as there have been studies that have shown that in the healing phase, they have a very positive effect on bone fusion and healing. And so, in conclusion, cementing has some benefits, but it also has some serious risks. There are other safe options that exist to increase fixation strength. And again, bone health should be at the core of our management in any one of these patients with osteoporotic fractures. Thank you very much.
Great job. So we'll have you take a seat over there in the hot seats, your choice of one of four. My partner, Dr. Amir Abdul-Jabbar, is our fellowship director. He actually was a medical student at UCSF, trained at LSU, and has a very nice potpourri of publications. Several of them are trauma. He loves spine trauma, and he loves getting called at 2 a.m. about osteoporotic burst fractures as much as anybody. But he's going to talk about cement. And again, he's a younger generation surgeon who is not opposed to doing what's necessary. So let's hear the argument in favor of cement.
All right. Thank you guys everyone for being here, and another great year so far. Just wanted to go through some of the things that I think of in terms of when we use cement, and some of the techniques as well that can minimize some of the negative effects. Obviously, as we talked about, I won't go over this at length, but increasingly osteopenic patients are having fractures, whether that be high energy trauma or low energy trauma. These patients we get called about almost every single day, and there's pretty wide scale. They can easily be treated non-operatively in the right case. In the cases of neurologic compromise or intractable pain, we're often having to operate on these patients. And so they will increasingly become part of our practices in the future. Just wanted to pull up a quick case here, run through it quickly, and just kind of show one of the good case scenarios. As we talked about, I will get into some of the negatives as well. This was just a fall from standing, was treated in an outside hospital, sent home, neurologically intact, but typically these patients will have some sort of urinary retention, 300 to 400 cc's PVR. Is that baseline? Is that, urinary retention that means they're neurologically compromised? We could go on forever about that. We'll just leave that there. and put into TLSO brace and sent out. Pretty sick gentleman, but literally was not able to get out of bed, so returned to the hospital with intractable pain. When you see this fracture, nothing, Jens, you talked about that 50% canal compromise. It looks pretty close there, but motor and sensory are intact. Pretty significant percentage of height loss there. But I think the biggest piece here that kind of forced us to operate was that we tried to get him up, tried to get standing x-rays, couldn't even stand. So it really forces you to do something to these patients. We talked about Hounsfield units, someone with this history and a fracture, do you really need it? A low energy fall, you could pretty much say that you need some type of augmentation regardless. But you can look at it with a CT scan, and I'll just kind of briefly go over some of those numbers. And typically, if we're doing an elective case, we have the gold standard of a DEXA. When these patients show up in the operating room, that's not really feasible. So there's no real consensus as to where that cutoff is. For a general rule, I've used 100. Again, how do you measure that? Just go through, it's important to know the standardization is at the L1 vertebral body. So if that level is not fractured, that's where the references are. You can just see there, I would go to that top box, the average for a thoracic level is significantly higher. So knowing where you are when you're using these measurements. And this is that going back to that patient, these are 80 to 100, not that bad. Often we'll see numbers in the 40s where I think it's absolutely necessary to use some cement augmentation. But again, I think history alone, you can use it. I think this is kind of the quicker way to do it, but technically it's an axial slice through 3 slices of the vertebral body to give you that average number. And then looking at screw augmentation, very robust evidence out there in terms of pull-out strength and rotational strength. Pretty wide variety in terms of with the different studies, but no question that it's significantly more than a plain screw. PMMA is most common, but has also been looked at with some other injectables as well. And for most of these studies, some that have looked at a kind of vertebroplasty or kyphoplasty technique and then placing a normal screw is fairly similar to the fenestrated screws. They're significantly more expensive, but I do think make the surgery go a little bit more smoothly. So, at every different institution, some of those are different concerns. And then, most look at linear pullout strength, which is what we're mostly concerned for, but also rotational force is significantly improved with that rotational twisting of the screw out, but not so much that you're going to destroy that vertebral body. If you do need to revise these screws usually come out with a little bit more force, but not so much that you're absolutely obliterating the pedicle. This just a couple more studies where they looked at, torque to failure with fenestrated and solid screws. Not a significant difference between solid, but they did see some improvement for the fenestrated above the solid, but both were 3 to 4 times greater than a unaugmented screw without cement. And I just wanted to talk about this briefly. Obviously, this is the main concern. This Janssen series from 2017, 1.2 was their percent of symptomatic patients. That translates to 2 patients with an embolism that caused significant pulmonary complications, and then 2 that had anaphylaxis. So, that's a 2.4% rate of significant complication in their series. Obviously, you really have to look at the amount of cement used, the technique being used. All of those things play a huge role in this, but it is something you need to discuss with patients. And we looked at that 67% with some extravasation. It's almost I would say maybe even higher, where you'll see a small piece of cement coming out. The vast majority are not symptomatic, but epidural leakage, again, 10 patients, 2 enough to where they thought that they required revision and went back in to remove that cement, which is an extremely challenging case to have to do. And just briefly want to talk about, things to keep in mind. The fenestrations are all very different on the different implants if you are using that technique, how far back the holes go, the total distance fenestrated, and you really want to make sure that your technique is sound in terms of cannulating the pedicle. A medial breach will create a pathway for that cement to come back into the canal, which is a very big concern. If you're putting that screw too deep, you can have it extravasate anteriorly, possibly into the venous system, causing that embolization. So really making sure you're taking time to put that trajectory in just the right place. And I use pulse live fluoroscopy to make sure if there starts to be any extravasation, you stop there and not push the limits to try to get a little bit better fixation. So just going back to our patient here, used about 1.5 cc's in these screws. These were fenestrated screws. You see very well contained. But up here, a little bit of extravasation into that posterior wall. And I'm going to pull this up here with the pointer. Thank you. But right here, having extravasation is going to be a very common occurrence. This was not enough to be symptomatic, fortunately, but unquestionably something to consider. Thank you, Jens. So, this patient did very well. Obviously, many of us use this technique. I think it's an important tool to have in your toolbox. And it's been very effective for me, but I think you do have to do it only in the cases that really need it, because otherwise you're putting patients at undue risk.
I think that's a really great summary. So do you want to have a seat over there? And so just quick questions, and then I'll ask Ashraf to start getting his lumbopelvic talk ready. So quick questions to both of you. I'll start with you, Amir. We both use cement. You use fenestrated screws, I don't. I'm worried that I have to put more pressure during the cementing of my fenestrated screws than if I do a preload of about 1.5 to sometimes 2 cc's in a pre-manufactured screw tract. Right or wrong?
I mean, we both get extravasation, right? So, yeah, I don't know that has been studied well. I think extravasation is a part of it. For me, I think that, being able to see it come out from the screw itself is really helpful. And I think that one of the challenges when you're doing the pre-cementation is timing, where you're having to get the appropriate amount in, get the screw in before it hardens. And sometimes if you put that cement in too soon, the screw itself can cause the extravasation by kind of pushing it out. I don't think that there's one that's better or worse. I think it's a matter of preference.
Question to David. So again, very nice lecture, and the multi-screw fixation, for instance, or artistic cortical screws. We have image guidance nowadays. We have the chance to do quantitative, selective screw placement with semi-intelligent CT-based kind of optimal screw trajectories. Do you place those screws, or do you suggest placing those screws with image guidance to get truly the maximum hit out of your screw placement?
I mean, I think that's another tool, and I think that's part of the wave of the future, to be honest. It's something that should be looked into.
Do you use image guidance then or not?
Not to determine the exact trajectory of the screw, but on occasion I will use image guidance.
So keep you two here. We'll listen to the next lecture, and then I'll show. You don't have a lecture, right? You were going to show it in the lab. So I'm going to substitute your lecture for a case that we'll take in there, okay? Perfect. So have you two, and then Ashraf and maybe Dr. McGuire take a panel seat up front. So Ashraf, great to have you here. Talk about lumbopelvic fixation, especially as we have so many fixation-challenged people.
Yep. No, and this is a subject I absolutely love talking about.